If we can welcome on the stage, Dr. Shah.
Thank you very much for the kind invitation to speak. So I've been tasked with talking to you all about circulating tumour DNA. These are my disclosures. What I thought I'd do is talk a little bit about molecular biology for a layperson, and then focus in on molecular biology of ALK, and then start talking about circulating DNA and what it is and the applications that this technology has in cancer treatment. So we've known for a long time that targeted treatments work really well. So this is a patient I looked after when I was a trainee, and those are CT scans on a celluloid film. Back in the old days, we used to use celluloid film. And those are the lungs, and you can see these round white things all over both lungs. Those are metastases from a cancer. So this is a very ill person who's a lifelong never smoker and in his 50s from memory. And he took a tablet, and 4 months later, they've all disappeared like magic. Amazing. So we knew these tablets worked really, really well, but we didn't really know what the mechanism of action was that allowed some patients to have such fantastic responses to these tablets. But now we know exactly how this works. I'm going to walk you through some of the things that underline how these targeted treatments work. So the first thing I want you to understand is that a very key component of our cellular structure are proteins. So proteins that's the structure of insulin on the top left, and they're different amino acids all bundled together in a very, very specific sequence, and that makes insulin. And we have tens of thousands of different proteins that are used in our body that have all sorts of different functions, your muscle, your brain, every organ is producing scores and scores of different proteins that have functions. And this diagram over there shows what's going on inside a cell, and all of those circles with some squiggly writing in is a protein that's doing something. It's existing in an off state, it's being activated by something, it's going into an on state, it's then doing something, activating other proteins. There's a signaling cascade going on involving thousands of different proteins inside our cell. And on the surface of the cell, you can see in red, is this thing like this. These are receptors, and receptors are receiving signals from outside the cell and resulting in activation of multiple proteins that cause signaling cascades to occur through a cell that results in changes in what the cell does, its behavior, like a muscle decides to contract, et cetera, et cetera. And a lot of these activities are managed through what we call enzymes. So there are protein structures that basically are powerhouses. They are able to do complex chemical reactions that result in the activation of another protein. And that itself has an enzyme in it that then is able to activate another protein, and so on and so forth. It's quite a complex system. So what this shows is that you've got a dark blue protein at the bottom in an off state, and then another protein with a kinase basically activates it by phosphorylation. It's a very common way that proteins get activated, by phosphorylation. So our cells are made up of thousands and thousands of proteins that are signaling, doing complex things all the time at a very, very fast rate. Now, step back from that and look at a cell. You all know that we're made up of cells, right? And you all know that we have our genetic code is encoded in our DNA, yeah? And inside a cell, a blue structure called a nucleus contains all of our DNA. So every cell that makes up all of our body has all of our DNA in it, half of which you've inherited from your father and half of which you've inherited from your mother. And that DNA encodes for all the proteins that are doing all these complex things in your cell. But DNA is just a code, it's just a blueprint that says this is how to make this protein. Somewhere in your DNA is a DNA code for insulin, and it says this is the structure of insulin, and somehow that message has to get through to a different bit of the cell that actually makes that protein. And it's got to read a blueprint, just like an architect builds a builder builds a building from diagrams that are done by a surveyor and an architect. There are factories that generate the proteins exactly as they need to be made, building together the exact sequence of amino acids to make that protein. So that black squiggly thing inside the nucleus is your DNA, and the blue two round circles over there in the cell is the factory that makes the protein. It's called a ribosome. And the yellow line is something called messenger RNA. Basically, you have your DNA code, and an exact copy of that is made. It's called a message, or mRNA. And that message goes out of the nucleus into the main cell, goes to a ribosome, and there the ribosome reads that code and constructs the protein exactly as it needs to be made. And that protein then folds as it needs to form the functional protein, which is that red circle over there. Does that make sense? So that's going on in our cells all the time. So we have really complex systems involving thousands of cell surface receptors with scores and scores of proteins that are second messengers, where, for example, that little red dot there is a ligand. It's something that binds the receptor, activates the receptor. Inside the receptor, there is a kinase that will phosphorylate a messenger, another protein, which will phosphorylate another one, and so on and so forth. There's a cascade of phosphorylation or activation of multiple signaling pathways that result in the activation of very special proteins that are able to actually go into the nucleus and change what the cell is expressing, right? Because a brain cell is not expressing the same proteins as a liver cell, as a nerve cell, as a muscle cell. They're all different. And your DNA code has at least 19 to 20,000 proteins encoded in it that are being used. And a cell is only using a small repertoire of that code. It's only selecting to use the bits that it needs for its functional existence. And in a cancer cell, we know that lots of these systems get abrogated, become abnormal, become abnormally activated. There are mutations in the DNA that encode for the protein. That means that that protein is no longer able to function in that normal, I'm off and I'm going to go on. They're permanently on, and they're activated, and they're driving signaling cascades that are causing the cancer cell to behave in an aggressive and malignant way. So that particular patient had a mutation in something called the epidermal growth factor receptor. So you've all heard of EGFR positive disease. You have a sister group, EGFR positive UK. It's a different mutation, but fundamentally at a molecular level, there are lots of similarities between EGFR and ALK. So here we have a normal cell. The EGF ligand binds the EGFR receptor outside the cell, activates the receptor. The little P's internally inside the cell are the enzymes that do the phosphorylation, and you get a signaling cascade. And what we know is that that EGFR molecule is encoded. It's a protein. So in the cell, there is a bit of DNA that encodes for the exact sequence to make that receptor. And DNA structure is very interesting. So there's always a flag at the beginning of a gene saying, this is the start. We call that a promoter. This is the start of this gene, right? And then there's the gene itself. But genes aren't just a continual sequence. They're bits of interesting coding sequences and bits of rubbish in between. They're broken up into what we call exons and introns, bits that are important and bits that are not important. So what happens inside your nucleus is a messenger RNA is made that's exactly the same as the DNA. It's a copy of that code. And then another complex thing happens where all the introns, the bits that are not needed, the green bits in that particular diagram, get cut out. And that makes the exact coding sequence for the protein, mRNA, and that goes out of the nucleus into the ribosome, makes a protein, and that's your EGFR receptor at the at the top that's been encoded by this DNA. And if you look at the gene for EGFR, so the gene has 28 exons, and if you look at that structure, you've got a bit that's outside the cell and a bit that's inside the cell. And the bit inside the cell, intracellular, has got this enzymatic activity, phosphorylation, kinase activity. And so what we know is that the bit, exons 18 to 24 of the gene, are the bit that actually encode for those kinases. And what we know is patients that have EGFR mutated lung cancer have mutations somewhere in that coding area, changes in the DNA that mean that the RNA has the same change because it's an exact copy, which means that when it goes to the ribosome and the ribosome makes that protein, it makes the protein, but there's something different. There's a mutation. There's a slight difference in the structure of that kinase. And that slight difference in its structure means that it's now permanently active. It's not behaving in a normal way. So this is that kinase bit, just the bit inside the EGFR cell, and tiny little mutations, even really single amino acid change can cause a structural conformational change in that enzyme that means it's now permanently on and driving the cancer. And that's targetable with drugs. So that yellow thing in the middle is actually an EGFR inhibitor. It's going into the kinase and blocking its activity. And that's what these tablets do. So here we have EGFR, we have the EGFR receptor, and we have these EGFR inhibitors widely used in lung cancer treatment, alatinib, gefitinib, afatinib, osimertinib, dacomitinib, which are all blockers of that overactive receptor where the inside cell, the kinase, is now overactive. But that's not the only way. So we have mutations in a gene that cause the production of an abnormal protein that drives the cancer to behave abnormally. But there's another mechanism that can do that as well, called a gene rearrangement. And here, I've already taken you through this idea that you have DNA, you make a messenger RNA copy, you go and you then, this factory called a ribosome makes the protein with a mutation in it. But sometimes what can happen is you can get a break in the gene. This is in the nucleus, in the gene of whatever protein you're talking about. It breaks, and you get a chromosomal rearrangement where the promoter from another gene gets transposed right next to this gene, right? And when that happens, what happens is a messenger RNA, if it all makes sense, if it's coding correctly, your cellular systems just, hey, this is a coding thing. I'm going to make this protein. It doesn't really have the intelligence to know this is an abnormal protein. So it's going to make a messenger RNA that has the bit of the promoter of the first gene, then the second gene, and that's going to go into the factory, the ribosome, and it's going to make a protein. We call them fusion proteins that have a bit of both genes. And that's fundamentally what's going on in ALK translocated lung cancer. It's generally, the classical ALK fusion is an EML4 ALK fusion, where you get an inversion in chromosome 2, where a little piece of chromosome 2 breaks, flips around, and what happens is two genes, ALK and EML4, suddenly the promoter of EML4 gets transposed to the end bit of the ALK gene, which has the kinase in it, and suddenly you have a fusion protein being generated that has a bit of the EML4 protein, which does nothing, but it's got a bit of the ALK gene, the ALK protein, which is a kinase, anaplastic lymphoma kinase, ALK. It's an enzyme, it's an activating thing, and it's in a permanently switched on state, and it's driving cellular growth. So this is a bit of molecular biology about different mutations that happen in lung cancer. So how are we going to detect this? Well, interestingly, we've got a huge number of options. We can detect, we've got technologies that allow us to sequence DNA, so we can go to the DNA of a cell and actually read the sequence. And a computer program, because it's thousands of bases, it would take you years to work it out, but a computer program can tell you, yep, there's a mutation here in the DNA. We actually have methods of looking at the RNA, so we can isolate RNA from cells and do analysis on there and see if there are mutations in RNA. And we can also look at the end product, the protein. And if there's an abnormal protein, we have systems that allow us to test for the abnormal protein. So we have huge redundancy in the testing of an abnormal molecular pathway like ALK, because we can choose to look at what we want to look at. And in the ALK space, if you look at the protein, we have an antibody, D5F3. It's a really, really good antibody. It's very accurate in detecting the presence of ALK, and it's really quick. You just put this antibody on a slide, look at it the following day, 24 hours, you can get a result, ALK positive or ALK negative. That's all it will tell you. It won't tell you anything more. And that's commonly used in many NHS facilities in the UK because it's really, really quick. But mainly what we do is we look at DNA. And there are different ways that we look at DNA. The classical way was a complex test called FISH. I'm not going to go into what FISH is because it's really been superseded, but we do occasionally do it. But most of what we do is NGS, next generation sequencing. So these are complex machines that are able to sequence vast quantities of DNA and backed up to massive computer programs that can analyze it really quickly and work out, yeah, there's an ALK fusion, there's an EGFR mutation, there's a RET fusion in this patient's genomic material. So a lot of what happens in the UK is NGS. The problem with NGS is it's slow. It takes weeks, 2-3 weeks, if not sometimes 4 weeks, before you get a result, because it's a very complex processing pathway. So immunohistochemistry, bang, overnight. NGS, you'll know exactly what the mutation is, exactly what the fusion is. You'll get massive molecular detail, but you've got to wait for it. And we even look at NGS using RNA. And in fact, for gene fusions, RNA is thought to be more sensitive. It's got a higher pickup rate. But RNA is a very unstable. DNA, you can go to a mummy from 3,000 years ago and isolate the DNA from that mummy and look at what kind of genetic mutations may have existed in Nefertiti or her children, etc. You can't do that, and RNA degrades very, very quickly. So RNA NGS is something that's done very commonly across the UK, but it's susceptible and liable to give you misreads. And you may know that in the UK, we're actually leaders in this because we have a national, NHS England, a national genomic hub system. So we have a national program that says any lung cancer patient will access NGS wherever they live in England. Still not happening in Scotland, but Scotland are working very hard to get something like this in place. Have you followed me so far? Okay. So now I'm going to talk about ctDNA. So we've got these genomic mutations in patients. We've got systems to detect them. Some of them take a day, some of them take 5 days, some of them take 3 weeks. I forgot to mention PCR-based. That's a star there, because I just wanted to mention it, because there are some systems that use a system called PCR. It uses small amounts of DNA. It gives a result very quickly, but it's not comprehensive. So some places still use PCR-based reactions, but you can miss things, right? They're not comprehensive. They're not anywhere near as accurate in their assessment of mutations as NGS. So ctDNA refers to the fact that in some patients, you think about a cancer, you've got a lump of cancer, you've got millions of cancer cells. They're not all alive. Some of them are dying, some of them are being born. It's a dynamic, evolving thing, right? And when cells die, they burst and they release their contents into the environment that they're in. So in some patients, very small amounts of DNA leaks into the blood system. In your blood, you will have, just floating around in the serum of your blood, very small amounts of your own normal DNA. And if you're a cancer patient, you may have small amounts of cancer DNA floating around in your blood. And that lends itself to technologies to use a blood sample to potentially detect for the presence of mutations, as opposed to a traditional biopsy where you actually have to get a piece of the cancer. So when you get a piece of the cancer, you have a lung biopsy or an EBUS biopsy, you actually have a piece of the tissue. So a pathologist can cut it, look at it under the microscope, can say it's an adenocarcinoma, can say it's a squamous cell carcinoma, can do immunohistochemistry on it, can characterize the cancer, can tell you with immunohistochemical stains that this is a breast cancer, a bowel cancer, a lung cancer, and then what's left after that can be sent for genomic testing. When you're looking at circulating DNA, you don't have that finesse. You're just taking a blood sample from a patient and you're amplifying tiny amounts of DNA that are floating around and then molecularly testing it in the hope that you might pick up the presence of a mutation or not. And it's actually a really, really powerful technique because you can pick up mutations, you can pick up whether a gene is amplified, so another mechanism apart from mutations and apart from gene rearrangements that I've talked about, which are what we generally deal with in lung cancer. In some other cancers, amplifications of a gene. So instead of having 2 copies of a gene, you've got 30 copies of a gene. So it's driving the expression. That's a common issue in some forms of breast cancer. So gene fusions like ALK, DNA methylation, we don't need to go into. But basically, you can take a blood sample from a patient and look and hope that there's bits of fragments of DNA that are floating around, and you can subject that to molecular testing. So the main application of this technology is in making a diagnosis or molecularly testing a new patient. So a new patient with lung cancer comes to the clinic, whatever the symptom is, they've had scans, there's a lung mass, there are bony deposits, whatever the story is, there's advanced lung cancer, and you're going to do a biopsy to prove it. But then what you want to do is you want to subject that biopsy to molecular testing, because as we know, many patients with lung cancer have molecular mutations that are actionable. ALK is just one of many, right? So I want my patient to have a biopsy, I want to have scans done so I know exactly where the cancer is, and I want comprehensive molecular testing. I want complete confidence that if my patient has got ALK or EGFR or ROS1 or whatever it is, I know it, because it affects what I do to a patient. And if they haven't got it, I want complete confidence that they have not got it, because I'm going to give them a different treatment. So for me as a doctor, it's absolutely critical. And in lung cancer, there are lots of nuances. Lung cancer, many patients have foci of disease that are quite difficult to biopsy. You know, having an EBUS is not a pleasant experience for many patients. Having a lung biopsy is invasive, it carries risk. So you can see that there are advantages in the lung cancer space to being able to do molecular testing from a blood sample. It's quite quick. You can do a ctDNA analysis. When it hits the lab, they can usually turn a result round within a week. It may take a week to hit the lab, and it may take a few days for the lab to get it back, but the actual lab processing bit of it is quite substantially quicker than normal NGS. It'll give you information on the exact fusion construct or the exact gene mutation. And it will also pick up lots of other co-mutations, because many patients with ALK are not the same. Some patients just have ALK, some patients have co-mutations in other genes like TP53, BRCA, all sorts of other gene mutations, which are not part of our normal lung cancer testing directory, but would be reported on a ctDNA and may influence what you do as a patient, as a doctor. And what we know is that molecular analysis of tissue and molecular analysis from blood are not the same. They largely overlap, but sometimes tissue testing will pick up something that's not detected in blood, and sometimes blood will pick up something that wasn't detected on tissue. So they're complementary. So gold standard molecular testing, if you want the absolute best molecular testing, I would say you should have a tissue biopsy, tissue NGS, and a ctDNA done at diagnosis. And these ctDNA technologies, there are two main companies, there's a lot of different technologies out there. The two main ones that get used in the UK are commercial products called Guardant and Foundation One, which are relatively similar. And they test, 80 to 100 genes, depending which system you use, and they're very comprehensive. And so they're multi-gene testing, and it's cheaper to do that than it is to do single gene testing, right? So we've now moved into a world where we just get a patient with lung cancer and we just multi-gene test them. In where I work in Kent, we don't even wait for what the stage is. We don't wait for the MDT. We know how important it is to get patients molecularly tested. Our pathologist, if they see lung cancer under the microscope, they will send off for comprehensive molecular testing like a reflex without any further discussion. The system is designed to try and get that information ready for the doctor-patient consultation when the patient first sees their oncologist. And now we have this available in the NHS. We've all been using it itty-bitty. It's been used in the private sector for a while, but in the NHS it's been something that patients have had to pay for many years. And you would get very variable access to this because not all oncologists are comfortable bringing up a test with a patient that might cost £1,500 or £2,500. So it's often not discussed at all. But now this has been commissioned in NHS England, and we have a project called the Transformation Project. And this is predicated on this idea that if you get somebody right at the beginning of the pathway, you've all heard about 62-day waits. In the NHS, we aspire to treat someone within 62 days. Well, that sounds like quite a long time to me. We aspire to treat patients much quicker than that. And this is an attempt to do exactly that. It's looking at the pathway and saying, well, someone has a scan that looks like lung cancer, then they have their biopsy, then it takes 2-3 weeks for the, 4 weeks for the normal histology to happen and the molecular testing. If we do a blood take on the patient right at the beginning, when they're coming in for their biopsy, and we do a Guardant or a Foundation One medicine test, it's literally a blood sample taken from the patient, maybe we can massively cut down the pathway, the wait times to access cancer treatment. And that's exactly what this program is doing. So we now have routinely available in the NHS access to ctDNA for patients who are suspected to have lung cancer. We even have changed the reimbursement for many treatments so that we can treat a patient if we think it's lung cancer and we've got a molecular result showing ALK. I don't have to wait for the histology. I can just start the patient on an ALK inhibitor straight away, which is amazing. So let's give some examples. So last week I saw a 39-year-old patient with stage 4 lung cancer. We do ALK ROS1 immunohistochemistry. Both were negative. I mentioned PCR, so we also do one of these as a screen, PCR, because it's very quick. So he had PCR. This would have told me about EGFR, it would have told me about KRAS, would have told me about BRAF, would have told me about several fusions. All of that was negative. And the patients come into my clinic and their tissue NGS is still awaited. It's been sent to my genomic hub, and I know from experience that that result is still 2 weeks away. But the patient had a Guardant 360, it's called a Marsden 360, when he was originally diagnosed, and that result was available. And this is that result. And basically what it shows is a rare, uncommon EGFR mutation called an exon 20 insertion. Now, that's absolutely actionable. And none of these technologies that we use would have detected it. The tissue NGS will detect it, so I'm very confident that in the next 2 weeks, that result will come to my clinic showing he's got an exon 20 insertion. But in clinic, I had the information that he had an exon 20 insertion available, and that's purely because he had a blood draw done. Okay? And so I've referred him for a phase 3 trial of an exon 20 inhibitor, and I've bought extra time so young men, he can start sperm banking ASAP while that's being worked up. Let me give you another example. So this is a 57-year-old man. He's actually a medical consultant, gets back pain and cough, has a scan showing a left upper lobe mass, lymph nodes in the chest, bony deposits, and a deposit in his gluteum. This is his PET scan. You'll see things lighting up in the chest. It's all cancer. Bright yellow stuff is cancer. You'll see some bony spots if you look at his spine further down. You'll see some bone spots. There's a pelvic bone metastasis. So that's a PET scan. So that's stage 4 lung cancer. This is the EBUS biopsy, and it's basically showing a TTF1 positive adenocarcinoma. This is what the pathologist has done. And then he sent off molecular testing. And this is our in-house molecular testing. The first thing we get, ALK, ROS1, immunohistochemistry, and PD-L1, 3 things. ALK is positive, PD-L1 is greater than 50%, ROS1 is negative. That's within 1 to 2 days, really quick. Patient's a lifelong never smoker. Within 5 days, I have the PCR reactions. And what these show is no EGFR mutation, but you'll see it says ALK fusion detected. So there's a PCR thing called the IDILA fusion panel, fusion cartridge, and it's shown an ALK fusion. This patient also had a ctDNA done at the time of his biopsy, and that shows an EML4 ALK fusion. He sees me in clinic, starts targeted therapy. Now, the in-house, I went through the reports the other day, the in-house molecular stuff was reported on the 11th of July, and the Marsden 360 result was emailed to me on the 10th of July. So those 2 results came bang within each other. He sees me in clinic on the 15th. This is a relatively small hospital, so they don't have stacks of alectinib ready to give a patient. I have to do a blue tech form. It's ordered in, especially for that patient. So there's a 5-day wait before this patient actually starts targeted therapy. But the GLH report came 2 weeks later, and scarily, it was negative. Didn't show an ALK fusion. So that's caused a lot of anxiety, and there have been multiple communications between us and the GLH trying to work out how could this test have failed. It's been repeated, and it's repeated positive. But that's actually, as a doctor, I find that terrifying. You know, it makes you think there could be patients with ALK out there who are halfway through a lung cancer journey and no one knows they've got it. So ctDNA does all sorts of things. It picks up mutations as to whether they're pathogenic or not. It can pick up germline mutations, so things that are genetically inherited. It can pick up all sorts of normal things or things that are not significant. So your bone marrow, as you age, your bone marrow develops mutations. It'll pick up stuff in there that are not cancer mutations. So you can get a lot of molecular noise of mutations that are not relevant to your patient. But there are huge applications to this. So I've just talked about molecular profiling a new patient with metastatic disease. But potentially, could we use this technology to monitor response to treatment? Could we use this technology to monitor what happens when a treatment stops working? How has the cancer changed its character? Can we use this in early lung cancer? Can we detect cancers before? This is using colon cancer as a diagram, but forget that. It's applicable to any cancer. Can we detect cancer early using ctDNA? Can we decide who needs post-operative treatment? Someone's had a lung cancer removed. Can ctDNA help select patients for adjuvant treatments or not? A key area that we're interested in is something called acquired resistance. So what we're talking about here is patient, ALK, we'll use ALK, they're on alectinib or brigatinib for 4 or 5 years. It's not working now. What's happened? Why is it not working? It's not working because the new mutations have occurred. So the presence of the selection pressure of this ALK inhibitor has caused new mutations to appear that mean the kinase has now got a new mutation in it, which means the alectinib can't bind anymore, can't block its activity. Or, so we call those on-target mutations in ALK itself, but lots of non-target mutations can happen in other genes, BRAF, EGFR mutations, all sorts of things. So when we map acquired resistance, we'll do a tissue biopsy, potentially a liquid biopsy. And in the ALK space, this is where things get rapidly sort of experimental, because the drugs are not really tested by specific mutations. So we're not really we have licensed approved treatments. We're now using second generation ALK inhibitors. We're moving to using third generation ALK inhibitors for all patients. We may move to using fourth generation ALK inhibitors. But a lot of us are wondering whether we should be more nuanced in the decision making about which ALK inhibitor. Can we select the right ALK inhibitor for the right mutation in ALK and map the new mutation that's occurring and say, well, actually, of all these different mutations, because of that mutation, of all these different ALK inhibitors, this is the right one for this patient. So all of this is kind of in the realms of experimental medicine at the moment. And just a few weeks ago at a big cancer meeting, we were introduced to this new valent ALK inhibitor, a fourth generation ALK inhibitor. So this, my colleague is going to talk about this shortly, but this works on resistance mutations. We know that when ALK patients start progressing on alectinib or brigatinib or lorlatinib, it's because one of the mechanisms is they can have lots of single ALK mutations or even very complex ALK mutations. And so we're now developing inhibitors to try and block that. So moving into the future, where is ctDNA going to impact care? Well, it's going to impact care in the diagnosis of ALK patients. So I think far fewer ALK patients will get missed. I think most will get detected. We'll be able to map acquired resistance to select optimal second, third, fourth line therapies more. We may be able to serially monitor patients. This is a highly contentious area. Should you have a ctDNA every 6 months, every 9 months to map whether things are going on? But we're very concerned oncologically because there's a danger that we might stop a patient on an effective treatment earlier than they should. We don't know. We might be able to select patients for escalating therapy. Is just an ALK inhibitor tablet right? If you have multiple co-mutations, should you have that inhibitor with chemotherapy when you're diagnosed? There's some evidence in the EGFR space that that may indeed be the case. And then one of the new things in the ALK space is some patients are getting detected early and they're having lung cancer resections, and we now have an approved ALK alectinib as an adjuvant post-operative treatment to improve the chance of cure. So that's not reimbursed in the NHS yet, but I suspect will be very shortly. But will ctDNA allow us to select who needs it? Will it allow us to select the duration that you're on that ALK inhibitor for? Should you be on it for 2 years, 4 years, 8 years? Should you be on it for life? We don't know. So that's all I was going to say. I hope that was helpful.
Any questions for Dr. Shah? Put your hand up, and the mic, there's one hand over there. Have we got a mic? Sorry.
Is it me?
Rebecca.
Is it me again? Sorry.
It could be.
Sorry. Do you foresee a time where the cost of these doing these NGS analysis and ctDNA is low enough that it almost becomes part of your regular bloods, and it maybe informs when scans happen and things like that?
Yeah, I think we're a long way away from that.
Yeah.
I mean, there's an issue about cost, but then there's the issue about, does it really need to be done that frequently? And you know, are you in danger? You've got a patient who's on a treatment that's working really well. If you see something happening going on liquid, what does that mean? If the scans are all clear, if the CT's all clear, the MRI of the head's all clear, does that mean you should change treatment then or not? And these are all actually very, very difficult questions, and they need to be tested in trials, right? So we need to do trials to actually answer those questions.
Yeah, that's not a straightforward trial.
No, it's not.
Should we be asking for a ctDNA test if there's any progression?
Well, Yeah, so I think if a lung cancer patient is progressing, I think molecular profiling is correct, and that would be tissue plus or minus ctDNA. Now, some patients will end up having a tissue biopsy anyway, right? Strictly speaking, the NHS transformation project is for newly diagnosed lung cancer patients. So it's not really there approved as a serial monitoring thing. So it's not funded in that context. But I would generally always get tissue, if possible, and then genotype that and see what it shows. And I think if you have really good tissue and you've got really good DNA and it's been subjected to NGS and it's had RNA and DNA NGS done and you've got a good result, do you really need to then go and spend your own money on a garden or a foundation medicine? Well, maybe you do, maybe you don't. I think that's debatable. I don't think there's a hard and fast. I wouldn't push it, but I would push it if, for example, I had a patient who had progression that was very difficult to biopsy, right? If a patient had disease growing in the center of their chest and the only way to access it were to do an EBUS, I've got several patients who've been saved an EBUS by having a ctDNA test because it's picked up the relevant mutation and they've moved on to subsequent therapy. So that seems to me a very logical place to use it. But look, gold standard, ctDNA, tissue, complementary. If you're going to do tissue, why not do ctDNA at the same time? I think if you've got a patient who's progressing, I think that's a reasonable strategy if you can access it.
Yeah, do you foresee a future where, this may well be in some decades in the future, where ctDNA tests could be done regularly on the public, perhaps every 5 years, and then hopefully detect not just lung cancer, but a whole range of different cancers?
Yeah, so there's a whole, it won't be looking for ALK mutations. There are other signatures, methylation signatures, other mutations that might predict a patient has an early lung cancer, an early cancer of any sort. So that is inactive. I mean, can you imagine the potential profits available if you had a test that would detect a cancer early? So there's tons of research going into this. Whoever invents the test that detects cancer at stage 1 is going to be a very, very wealthy person, right? So there's billions going into answering that very, very question.
Is there any sort of data at how effective at the moment it is at?
I don't think there's anything that's usable in real, today, in clinic.
Thank you.
Can I ask a question?
Just a quick question. The ctDNA, if there's progression elsewhere but outside of the lungs, what advice would you give with regards to that?
So, I mean, I think I would generally look for a tissue biopsy if it was possible, right? So if a patient's had a tissue biopsy of whatever distant metastasis they've got, you've got tissue, you can do all sorts of molecular testing on that and get pretty much whatever answer you need. And it's very likely that will show whatever you need to show. It's very unlikely, statistically, that the ctDNA is going to pick something up that the tissue isn't. It's possible, but it's unlikely. So you could wait for the tissue results to come through in a few weeks, and if it's demonstrated that there's a new ALK resistance mutation and right, I'm switching to the next therapy, it's not really, I don't see that ctDNA would add value. If the tissue is non-informative, then definitely I would have a ctDNA. I think that would be a very reasonable thing to do.
I have a question. Firstly, thank you for the talk. It's amazing. I'm a doctor, also a patient. I was diagnosed 1.5 years ago. My oncologist never requested the NGS, and even though 1 year later on the alectinib, I had progression, she didn't request it. And her argument was, why request something you will not act upon, which I found unacceptable. I've had to go through radiotherapy, so I probably have responded, I don't know yet. and there may be no tissue to be biopsied, if I manage to change her mind, is there a role for me to have the ctDNA, for example, privately? Is there a benefit in this? And if I have it, would it help me direct or decide my therapy in the NHS or elsewhere?
Yeah, well, I mean, I think it might help. Every patient's got a different story, right? So, I generally don't go around doing ctDNA willy-nilly on random patients of mine who've got no evaluable disease, who've got ALK and are doing really well on treatment, and their scans are clear. Right? I don't go around, I think about it the minute things start changing. Any evidence of any progression, brain or outside the brain, if I have any sense that my first-line therapy, I mean, my idea is there's only so many treatments we have. We haven't got an unlimited number of treatments. I want my ALK patients on first-line ALK therapy to get the absolute maximum benefit of that therapy. And in the NHS, you can't go back and, have chemo and then go back to alectinib. Once you bail out, you're out. You're not going back on that drug. So I want absolute confidence when I take someone off that I'm making the right decision.
And is it possible, the historical biopsy, can someone reuse them? For example, I had biopsy a few months ago. Can they go back to a sample and do NGS on it?
One of the things that makes oncologists that treat lung cancer crack up laughing is when someone has their original biopsy tested 2 years down looking for acquired resistance. Acquired resistance needs fresh biopsy. You need to know what's going on today, now. What's changed? What happened 3 years ago, 4 years ago is of little relevance. So occasionally that has happened where patients have come in for second opinions. You find out that the supposed repeat NGS was actually NGS done in the original biopsy some years ago. It's quite comedic, actually.
Thank you very much.
But anyway, it doesn't happen now. It did happen a few years ago. Good. I think I'm off.
No more questions? Good science. So yes, that was a great science lesson for us all. So I hope you will all find it very informative. I think the one take-home message I would have from Dr. Shah is, when you get progression, get rebiopsied. Understand what is driving that progression. It isn't standard on the NHS to do that, so you might have to make yourselves very unpopular with your oncologist. But personally, if my life depended on it, I'm happy to be as unpopular as I need to be. Our lives depend on it. But that's the take-home message I would give from Dr. Shah. If we ever get progression, or when we get progression, we should always get a rebiopsy. So I hope everybody picked that up. Great. Thank you very much. Thank you very much indeed, Dr. Shah.